All right, let's jump right in. Welcome to the grand finale of our Emergency Department Facility Coding Explainer series. Today, you are stepping into the role of the ultimate quality control inspector for a hospital's billing assembly line. We've covered a ton of ground in previous sessions, from facility levels to the wild world of critical care, but today is where we pull it all together. Today is about making sure everything you do actually holds up under a microscope. You are the absolute last line of defense before a claim goes out the door, and we're going to show you exactly how to protect your hospital from compliance failures. Here is our roadmap for this final shift. We'll start with the billing Wild West, move into the new payment system, break down the 11 CMS rules, uncover major audit traps, and finish up with your final compliance checklist.
Section 1. The Billing Wild West. Let's look at how things used to be.
We're starting our shift by looking backward at how hospitals historically got paid before the modern rulebook even existed. It's kind of hard to imagine now, but there used to be almost zero standardization. For decades, hospitals were paid based on whatever they spent. Imagine a factory just passing all its inefficiencies and wasted money directly to the buyer. That was the cost reporting methodology. If a hospital had higher costs, they literally just got higher reimbursements. They'd report their cost to Medicare, and the government just paid a percentage of it. You can probably guess why that didn't last, right? There was zero incentive to be efficient. That all ended when the government forced a massive shift with the Federal Balanced Budget Act of 1997. This law completely rewrote the rules for hospital outpatient services, leading directly to August of 2000, when CMS finally implemented a brand new system.
Section 2. The New Payment System. Let's see how things work today.
So under this new system, we have two main buckets. DRGs are flat rates for the overnight warehouse, the inpatient side. APCs are flat rates for our drive-through, the outpatient ED. If you get admitted to the hospital, your care falls under diagnosis-related groups. The hospital gets a set amount of money based on that DRG, no matter how many bandages or hours of nursing they use. The government wanted that exact same predictability for outpatient services like the ER, so they created ambulatory payment classifications, or APCs. Just like DRGs, APCs give the hospital a prospectively defined fixed payment.
The entire framework governing this is called OPPS, the Outpatient Prospective Payment System. OPPS is basically the federal rule book that enforces these flat APC rates. It ensures a hospital gets paid for the facility resources it uses, the nurses, the room, the equipment, the supplies, in a highly standardized way. Every time you assign a facility level, like a 99285 for a complex visit, it maps directly to a specific APC that dictates exactly how much the hospital is going to get paid.
Now, the biggest takeaway here is that your job as a facility coder is entirely separate from the physician's billing. You are strictly tracking the hospital staff's effort, equipment, and supplies. APCs apply only to the hospital. The doctor who treats the patient bills entirely separately under the Medicare physician fee schedule. Think of it like renting a garage to fix a car. The hospital provides the garage, the tools, and the assistant mechanics. That is what the APC pays for. The doctor's the lead mechanic, and they send their own separate bill for their specific expertise.
Section 3. The 11 CMS rules. Let's open the manual.
Let's look at the exact 11 expectations demanded for every internal ED billing matrix. Since there's no single national standard for how to assign ED facility levels, CMS makes every single hospital write its own guidelines, but they have to follow these strict criteria. The first 6 rules demand that your facility guidelines genuinely reflect the intensity of hospital resources used. No gaming the system, no unnecessary paperwork. Rule 1. Relate the intensity of the hospital's resources to the different levels of effort. A Level 5 code has to represent a massive use of hospital resources compared to a Level 1. Rule 2. Base this purely on facility resources, not what the doctor did. 3. The rules have to be crystal clear so payments are accurate. 4. Meet all HIPAA privacy standards. 5. Do not force nurses to write down useless information just to bump up a code. Documentation has to be clinically necessary. And 6. The system can never, ever be rigged to artificially inflate codes.
The remaining rules are all about consistency on the factory floor. If an outside auditor inspects your work, your coding logic has to hold up and be applied equally to every patient, every single time. Rule 7. You can't keep these guidelines in someone's head. They must be written down. 8. They must be applied exactly the same way to every single patient. 9. You can't change your rules every month to try and maximize revenue. They have to stay stable. 10. If a Medicare administrative contractor knocks on your door, you have to be ready to hand them your rulebook. And 11. They must be able to use your rulebook to perfectly verify your coding decisions.
Section 4. Major Audit Traps. Let's look at what gets hospitals in trouble. All right, let's walk the factory floor and look at real-world mistakes. Trap number 1 involves a patient who checks in, gets triaged by a nurse, but then bails before the doctor arrives. This happens all the time, right? The waiting room is totally full, a nurse takes their vitals, maybe gives them a quick evaluation based on a standing order, but the patient gets tired of waiting and just leaves. So, can you bill Medicare for that lowest level ER visit just because hospital resources were technically used?
The answer is a hard no. You cannot ship a product without the manager's signature. Without a specific physician order, that triage visit is completely unbillable to Medicare. CMS is extremely clear on this. That limited service is not within a Medicare benefit category because it wasn't provided incident to a physician's service. Hospital therapeutic services and supplies have to be under the order of a practitioner. And no, a nurse acting on a general standing order absolutely does not satisfy this requirement. If the doctor didn't see them and order anything, you cannot bill it.
Trap number 2 is double dipping, which is exactly like charging a customer for a car's engine and then charging them again for the labor to put it in. In facility coding, you score points based on interventions to figure out your overall evaluation and management level, your EM level. But you also bill for certain procedures separately, like an IV push or an injection. If you bill a code for an IV injection, you cannot also take the nursing time it took to give that injection and use it to bump up your overall EM visit level. You have to keep the effort separate.
Trap 3 means you have to aggressively subtract the time spent on non-bundled procedures from your total critical care minutes. Critical care is billed based on time, but certain major procedures have their own completely separate CPT codes that pay independently. If a doctor or nurse spend 20 minutes performing CPR, placing a central line, or an ET intubation, you bill those specific codes, but you must subtract that exact 20 minutes from the total critical care time you claim on the chart. If you claim the time in both places, you fail the audit. Finally, Trap 4 is hitting the emergency factory alarm without proof. You cannot bill a trauma activation without hard documentation of pre-arrival notification from the field. Trauma activations pay a massive premium because the hospital has to instantly assemble a team of specialists. But you can't just slap a trauma code on a chart because a patient looks really hurt when they walk in. There must be strict adherence to the rules, which means formal field triage criteria were met and pre-arrival notification from EMS was documented in the chart. No documentation, no trauma activation charge.
Section 5. The final compliance checklist. To ensure you never fall into those traps, let's lock in the definitive, practical checklist you will use every day on the job. Before you finalize any ED claim, run this strict 5-step quality control check. 1. Check the chart. Is there a physician order, or did the patient leave without being seen? 2. Look at your points. Are you accidentally double-dipping facility resources with separately billed procedures? 3. If it's a critical care case, did you subtract the time for non-bundled procedures like CPR? 4. If it's a trauma, where is the pre-arrival alert from the ambulance? And 5. Does the final code perfectly match your hospital's written, stable interpretation of the 11 CMS guidelines? If you hit yes on all 5, you are good to hit submit.
You now have the complete picture, from the history of APCs to the 11 mandatory CMS rules, right down to the exact traps that get hospitals fined. You are the quality control inspector. It is your job to ensure the facility is paid exactly what it has earned for the resources it spent, nothing more and nothing less. So as the absolute last line of defense in the billing department, will the claims you approve today survive a Medicare auditor's inspection tomorrow? Thanks for joining me on this explainer, and good luck out there on the assembly line.